Good afternoon. Tough act to follow, but I'll try to convince you Hartmann's and complicated diverticulitis, why you shouldn't. So these are my disclosures. I'm going to begin by saying that I have nothing against Dr. Hartmann. He was a pioneer in the field. He described the procedure in 1923 as an alternative for a cancer operation, and he meant it to be a final operation. So no attempt for GI, reapproximation. And I will say that I agree that if you haven't used an EEA stapler and you don't know how to use one, then yes, you should probably just do a Hartmann's. But if you're familiar with an EEA stapler and you're familiar on how to do a GI anastomosis, then you should consider doing the anastomosis, especially in this patient who is not hemodynamically unstable. She's been in the hospital 10 days. She's now passed, had it been 10 days prior where she showed up in AFib RVR, then potentially a Hartmann's would have been the right situation. But now 10 days later, she's stabilized from a cardiac standpoint, and she's essentially not acute. She's more of a kind of smoldering picture that isn't getting any better. Okay, so just as in 1923 when people did not get reconnected after Hartmann's, that's true in 2022. So there's multiple studies that do show that once you have a Hartmann's, that's pretty much how you end up. So in 2004, when they looked at over 1,000 patients, the reversal rate was only 65%. In 2009, it was 45%, and when there was an attempt to reverse, morbidity was about 44%. And so we do know that is technically challenging and is fraught with morbidity and mortality. In 2005, looking just at surgical complications, a Hartmann's reversal was 43.8% versus primary anastomosis at 26%. So a higher complication profile for a Hartmann's. And then post-op complications also, again, in another study in 2000, favoring doing a primary anastomosis. So is a primary anastomosis safe? I agree, some of the studies did not include a patient such as this, but actually some of them did. So let's look at 2006. So small study, but mortality, 60% with the Hartmann's versus 11% with a primary anastomosis. This was a large study, 54 studies that included Hartmann's procedures and 50 studies with primary anastomosis. Mortality was 19.6 versus 9.9%, SSI rate 29.1 versus 9.6. And one thing to consider with a permanent stoma is the stoma complications, especially with a morbidly obese person. If you've ever had to deal with a retracted or a stoma that you can't pouch, you know that this is a very quality of life altering problem and not easy to fix. 2006, almost 1,000 patients, again showing that primary anastomosis is safe, mortality 4.9% versus 15.1%, and in their emergency patient cohort, the mortality was still higher in Hartmann's at 15.6% versus 7.4%. And when they looked at the patients that had Hinchy greater than 2, which potentially this patient would qualify, there was no increased morbidity with doing a primary anastomosis. Again, 2018, 17 studies, SSI rate and non-reversal rate lower for primary anastomosis. It was slightly longer operative time in this paper. Multi-center trial, which was stopped early, 30 versus 32. Overall morbidity and mortality, there was no difference. But if you look at the reversal rates, 90% for the primary anastomosis with a proximal diversion versus 57% for a Hartmann's. Serious complications, 0 versus 20% with the Hartmann's. And in these studies, OR time, length of stay, and costs were lower for the primary anastomosis group. And so in 2014, ASCRS changed their guidelines and revised them to say that a primary anastomosis with or without a proximal diversion is a very reasonable option for perforated diverticulitis. So in conclusion, a Hartmann's procedure is a safe operation, And if you don't know how to use an EEA stapler, then yes, that's the operation you should go with. It does carry a significant morbidity for reversal and a great risk for non-reversal, which may not seem like a big deal at the time, but you have to consider that this is a morbidly obese patient who may likely have stoma issues down the road that she and her family will have to deal with. So a consideration for a primary anastomosis in this hemodynamically stable patient is very appropriate. And with her significant comorbidities and obesity, she's going to have a very low chance of having a reversal and a high risk of morbidity should a reversal be attempted. And I'll end by leaving you with kind of two final thoughts. One, what would you want done in a case if you had complicated diverticulitis? And two, before making your final decision, picture this patient and her family back in your office requesting a reversal. Thank you.